That's all for vaccination. General hygiene, that means also, cleaning of the workplace, foodborne illness. You have it because you feed on your patient and personnel. Hand washing, evaluate compliance, we talk about that. Substance abuse, that means training, knowing the pharmacology, and there are some specific standards and criteria for that. Sterilization where it applies, but you should apply the same standards. Your small or your big bacteria and all those germs don't take care of small and big. You have to well organized, and that's what happened to mine. Investigating in mental health services. So we have confidentiality with an aspect of the security. There are some more, but on the security, having the right people, training, teamwork, violence, harassment, politics, procedures, or any kind of mechanism to decrease and analyze and treat if there's complaint on that side. And delivering mental health care, you have, and it's in the standard, reduce the risk of aggression and suicide, training in patient safety and security, medication, reconciliation. As you remember, when the British Columbia team made this huge literature review, you have all of that. So that means that Accreditation Canada already integrated those aspects in the standards. So it's the reason why I wrote, in the upper part, that standards in mental health are, maybe Sébastien will not agree, but it's, in a big sense, an episode of care plus. That means with special conditions, but the base is the same. Maintain patient information, patient, family, written information, the patient, usually you have some like that, and also something in the patient record or patient file attesting that this information was given or written or verbally, but there's some trace when you have surveyors asking, do you give information to patients? We always give information. How can I verify that? There's nothing to verify. When you have external evaluations, those people who don't know your organization will always ask, what do you have to give me to demonstrate that it's really in place? Monitoring the safety and quality of mental health services, physical hazard, meeting quality and patient safety indicator, accident reporting, quite the same as other specialties. So I don't think we have time, 30 minutes. I have an example from my hospital. Will it be interesting to you? So the name of my hospital is Institute University Mental Health, but in your term, it should be academic mental health or psychiatric hospital. I think it's related better to your situation. How it's written here. Okay. One of them is each year when we do our quality improvement plan, and you have the one in short for 2013. We have two sources for that plan. The first one comes from internal sources. One of them is surveys. Okay? We had a survey on safety culture for all our personnel, including physicians. And we have also a survey on the work environment. We have also, we do it every 3 years, survey on patient satisfaction. We were the first to do that for psychiatric patients. I think it's 7 years ago, the first one. The second one was made 3 years or 3 years and a half ago. And 2 years ago, I insisted to say that's good. It's the second time we do a client survey. Why don't we do a family survey? So the person who is more important for the patient coming to see him and seeking for information, we ask them to complete a questionnaire on the way we take care of them. Does the team or member of the team are ready to answer their question on information? Do they receive for themselves, not the diagnosis of the patient, but for themselves, do they receive good information to understand more the kind of services we have in hospitals, the kind of care their relative is receiving, and there's a lot of questions. So, and now we are preparing one for our partner. How in that way we are helping together, and are there some topics we should improve? And we also have complaint follow-up. We have in our province a law that we have under that law to have one person who is assigned by the governance to receive complaints, treat them, and make every 3 months a report to the governance. And that person has to make an annual report also. So we grab from those reports, are there some repeating area that we should improve. So those are internal sources. External sources, for sure, Accreditation Canada with all those areas for improvement. We take that. Other organizations also, sometimes College of Physicians will come for an inspection visit, the Order of Nurses or some other. So we take those recommendations, put them in the quality improvement plan, and we also have, I don't know the name in English, we call it VIGI, or what would be the name? Intelligence. Kind of radar, So the person in the quality improvement just take a few minutes on his or her computer sometimes to look around. Are there something coming in other countries or all over Canada that we should become preoccupied in the future because we see some more preoccupation about something? So it's the other one. We take that to make the plan, but you will see the plan is at the level of an organization who was accredited a couple of times before, so it's not the first one. So, sorry. There's something wrong because I should have that plan after. I'm sorry. Because, we have a second plan. This is the risk management plan for the same year. And, the major of that came from the recommendation of Accreditation Canada. So, to help increase the safety culture, we have to give a follow-up to the last safety survey because we had some things, coming from that. So it's the first part of the plan. Accident reporting, analysis, and disclosure. You know that you start it, you follow it, but you always have to push on it and make sure that people should declare, and that the declaration will increase if you do a good job, because people are more conscious and they will declare more than before. So it's not a bad think to have more declaration. But what we see when we follow it, that those incidents or accidents with really serious adverse effect decreases, and those ones with quite no effect are increasing. So that means the culture is going in promoting recognition versus blame. We never attain it to the 100% level. Violence and aggression prevention. All the personnel who have the training, our program is Omega. I think I don't say nothing to you, but it's a kind of approach who is prevalent in the whole province. So we have training for all personnel, even security guard, and I don't know who, everyone, but we have to make some, we have to repeat, because we had that 3 years ago, and we saw with incidents that we have to repeat it. Violence and aggression prevention, we have a good policy, but it's not applied at 100%. So we have to put some, some strain on it. Suicidal behavior prevention and screening, we put in place, I think it's 5 years ago, Sentinel. What's the name? Sentinel? Those persons was trained especially to have like a radar, mental radar, just to be able to screen if there's any sign between employees or patients that we can address, take care, and just be aware for a kind of screening. Medication error, it's never finished. We made some, some improvement, but it's still part of the risk management plan. False prevention, we're having better rate of non-false, but it's not finished. We have to put, the emphasis on it. And also, we saw that we had problem with first response, first aid program when something happened before a reaction, and the good people will be at the good place for the good time for those. So you see what it can look like, and then you have it on a plan with action was done, who's responsible, what's the indicator, and then we have checked because there's a committee following that on a 2-month basis. Infection and prevention and control program. So we have 3 programs, as you see. Quality improvement, and you will have many things in that. Risk management, you will have drug, and you saw that. And in infection prevention disease, we have to reinforce hygiene, universal measures, vaccination, again, those 3. We reached that a couple of years ago, and then it's decreasing. Why? I don't know why. But the why is that nurses are reluctant to vaccination. And other professionals say, if the nurse think it's not good to have vaccination, I don't want to have it. I don't think it's the same for you, but influenza especially, we reach, I think, 40% of our personnel who accept to have vaccination for influenza. And what we see is that our nurses, for any reason, do not support that. Hygiene and wellness, those are common infection, education. And we have audit also reprocessing because we have stabilization, as you saw. So there's not, 100 priorities, and we think we can make improvement on those aspects during the year, and it's part of the report, and we see what's going up, and we have some indicators that measure with rates and things like that. Yeah, well, I'm almost finishing. Almost finished because time is going, because I want to have time for questions. Let me show what's going on. Yeah, anybody would like to, just to show one, just one. You know those ROP required organizational practices, eh? You remember those ones? And we sent Sebastian and me that we have to reach them if we want to pretend participation. So you have those ones who apply to my hospital. And they are not specific to mental health. Maybe I have one for suicide or for things like that, but and violence is more important in our hospital than others. But you can see the follow-up we made for the implementation of those required organizational practices. And that, you know, that one was, I think, 1 year before the last visit, right? Because we are for 3 years accredited, and as it is an ongoing process, it was time 1 year before the next survey to see where we are and what do we have to improve. And we followed that at the board of directors a month during that year. Why? Because the first 2 or 3 months we had a lot of red here, and the person in charge, the quality coordinator, said, I can't do more. I went to the nurse direction, they said they're not able to do that. I went to the other one, oh, I don't have time to do that. And to the other one. So I said, improvement is start in the head of the governance and leadership. So we will follow that at the direction board committee. What do you think? Okay, because the director were there, and if there was a problem with the one in charge of the physical environment, what can you do to reach that one? And if it was the one from human resources, what's the problem to roll that thing? And then we found solution together, and it's the reason why you see some red and some yellow. Yellow, seeing the signification was it's in process. So it was started, but it's not finished. And you see that when you will reach, it was in 2 months before the survey, we thought, reached what we had to do with those practices. And when the survey came, that's what happened also. They found that it was done as a significant level. I think I will stop there.
Uvaženi predavanje, pogotovo vezano za ova vaša iskustva.
I'm working in the General Clinical Hospital in Novi Sad, and you said that it is in academic hospital easier to apply all standards. Okay, those about infection and etc. But the problem of patient safety, safer environment for suicidal patient, etc., it is not, the problem of a safe environment could be a problem. For start, do we start with standards, try to basic standards with basic recommendation, or we start what we have now and try to improve? Because when we, by our accreditation agency, have to put our standards, they ask us what we do and how we do, and let's just accreditation is a process. But we don't start from basic standards for mental health issues in the standard. We just have to make our standards.
I understand. Do you want to answer that?
Nisam baš dobro niste u smislu da li su standardi bazični?
Da, dakle, da li krećemo od ove, kako se zovu, da li krećemo
Od rokova?
Od ovih nekakvih
Obveznih.
da. Da li, jer oni traže da pratimo neke stvari, da popišemo procedure, da vodimo brigu o procedurama, to je sve jasno. A da li krećemo od nekakvih bazičnih standarda, odnosno da li vi kažete vi morate imati te i te standarde, odnosno dakle, pisane, gotove, već pripremljene i međunarodne standarde, ili vi radimo vlastite standarde?
Što se tiče međunarodnih standarda, znači to je akreditacija Kanada, vi dobivate već standarde koji su pripremljeni, koji imaju 3 različita nivoa, znači za zlatnu, platinastu i dijamantnu akreditaciju, znači koja vas vode od ovih bazičnih, to je bila zlatna akreditacija preko naprednijih i najnaprednijih. Znači ona vam točno daju smjer kojem idete ako se želite stalno poboljšavati. Što se tiče bazični, to je zašto. Što se tiče ovih rokova, znači to je spominjao dr. Vasin, to su obvezni akreditacijski standardi. Znači to su znači stvari, to su obvezne prakse koje vi morate ili ispunjavati ili padate. Znači na ovoj bazičnom nivou vi možete recimo ispuniti neki standard 50% da bi na neki način zadovoljiti standard, a ove prakse su znači obavezne, kao recimo, ne znam šta je bilo, hand hygiene je bila obavezna praksa, znači bile su ove kirurške liste, što je bilo za psihijatriju, recimo sigurna primjena injekcija, sigurna primjena injekcija, izbjegavanje, znači dostupnost koncentriranja možete elektrolita. Znači to ukoliko to ne zadovoljavate, ne možete dobiti akreditaciju.
Ali pitanje da li bi to moramo napraviti na psihijatrijskom ili moramo na nivou cijele bolnice?
Na nivou cijele bolnice. Znači na nivou cijele bolnice vi dobivate gotove standarde. Ne morate oni vas vode kroz cijeli proces.
Perhaps I can add also, and from what you're saying, it looks like a ISO or EFQM type model where you establish yourself the standard and you specify how you should improve upon it. ISO or EFQM is not very prevalent in healthcare institutions. The reason being is healthcare professionals want to base their decision on a commonly recognized criteria or measurable standard. It applies, I mean, there are universal applications. For example, the surgical checklist, it has universal application, whether you're in Croatia, whether you're in the United States or in Africa. It is scientifically based. So what the accreditation or a healthcare accreditation organization should do, at least that's what we do, is we establish what is the level at which you're providing a reasonably safe care based on a benchmark and bringing comparability in the same system. So if you have an organization accredited at that level, then you can infer that all of the organizations accredited at that level have a similar quality. And from an external perspective, from a citizen or from a government, at least you know that, okay, this is the level expected here. As opposed to ISO, you can't compare an organization to the other. I mean, if you do very well at a very low level, you're meeting your target or your objective at that level, well, this is what you are. As opposed to, well, healthcare accreditation was established that this is a base level. And it was established by a panel composed of WHO with people from different parts of the world, including Europe. And so it has universal application.
For example, patient restriction, for example, in the whole hospital on the same level, international status.
Yes.
Yes.
And I would say it's not easier in a general hospital. Maybe I say something like that, but the purpose is not that. It's only because in Canada, general and academic hospitals were faster to integrate such an approach, and psychiatric hospitals were far behind, because we said it does not apply to us, and all of that. And then try to take those tools before inventing some, because there's a lot of standards who are quite the same. And we learned a lot from general or academic hospital because they were quite in advance to psychiatric. And I'm lucky I learned about that to bring my own hospital in that group. Okay, so it's not easier. I think it's worse because there's so much specialty. But addressing the evaluation process, would you be in surgery? It's quite short. Would you be in medicine? It's a little bit longer. It's longer, but it's quite the same process. We have to evaluate, to have a care plan. Who will contribute? It's only the proportion when you look at its standard. But there's not a standard for evaluation in psychiatry, instead of being a little bit different than the other, but the frame is the same. Understand it? Okay.
Thank you. I have one question. Well, the title of this presentation, Mental Health Standards for Patient Safety. If I can say that lots of things that you said today can be applied generally, yeah. And I don't think that there were enough references to mental health specific problems. So my question would be, what set from your experience, you have lots of experience, you work in an academic university hospital in Quebec, what set of standards are most difficult to meet in mental health, in psychiatry hospital?
There's two kind of answers, the last one, but in between there is one that the standards are not the most you can do.
Yeah.
Any kind of standard is always a level you can demonstrate, but usually when you reach a lot of them, you are trying to go far. Okay? So we have to remember that. Being accredited doesn't mean the job is finished, we're good, and there's no more improvement. They said we have the higher level, we're diamond. Thank God, thank you everyone, we can sit down. You know what happens when you do that? You only can decrease. So we have to be aware, and even if it's not clinical scientific indicator, we can work on something else. And what we are working right now is more with partner. How to define the way we have to work together for the benefit of the client. And what we did last year, I financed a lean project with all those partners to say, and we had 7 meetings. We were accompanied by a lean management specialist just to analyze the pathway and see where we can reduce all those non-value action we were doing. This is not in the standards, but we were there. The most difficult, I think, is the culture of the organization. Usually it was the same in my hospital. In psychiatry, people are not on the place to say what they are doing well. There are people, who are not well accepted in the community, the patient thing, and I think our own behavior is the same. So this is our kind of culture, and we think we're so different that we cannot make the same as others. That's what I try to demonstrate. We're not so different, and maybe we cannot have to continue to say that we're so different that people will, in the population, will think also that we're so different. We are not a hospital like another. We're not treating good people as others. And you know what I mean, eh? So the first difficulty is there. The second one, I could say, I'm sorry for you, you have to make sure that you have one or two physicians who are supporting the approach. If not, you are hurting the way, this is the truth, all physicians were practicing 30 years ago where they had the sciences, maybe more than that, before 1950 we had no medication when it started, or you know all the history. That part is very important. You need to identify one or two who will integrate the approach and will speak about that with their colleague. And when they will speak about that with the colleague, psychologist, nurse, it's like, you know, it's very important that thing. That's what I can answer with my
Yeah, thank you.
experience.
Yeah.
Mostly all participants are physicians.
I'm sorry, I don't want to hurt anyone, eh? I know you.